call the meeting to order. Rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everybody. Lee D., would you please take the roll?
Director Wallace.
Present.
Director Stewart.
Present.
Director Nicholson.
Present.
Director Danielson.
Present.
Director Eatman.
Present.
Okay, Nancy, we're going to go into the educational session.
Yes, we are.
Yeah.
This evening, I'd like to announce that we'll have two sessions. The first is being presented by representatives from Healthgrades. David Bromal, who's the Vice President of Quality Solutions, Healthgrades, and Catherine Mongovan, the Associate Director of Quality Solutions. I want to tell you a little bit about them. David is Vice President of Quality Solutions with Healthgrades Hospital Division, works closely with hospital executives across the country, providing strategic guidance in the areas of quality improvement, quality management, and market development. He is charged with growing strategic partnerships with hospitals and health systems and helping hospitals grow market share, increase revenues, and improve clinical quality. He's been with Healthgrades for 6 years, supporting hospitals across the nation with quality improvement and marketing and market growth initiatives. He holds an MBA from Leeds School of Business at the University of Colorado Boulder with a concentration in management consulting and finance. He also has a Bachelor of Arts degree from St. Lawrence University. Also with him this evening, as I mentioned previously, is Catherine Mongovan. She's the Associate Director of Quality Solutions. She works with numerous hospitals, provide marketing and quality improvement strategies and insights. She has significant healthcare and consulting experience with expertise in market research, analytics, and improving healthcare marketing strategies. She also holds a 6 Sigma black belt for process improvement. Catherine holds an MBA from the University of Connecticut in market research and venture consulting and a Bachelor of Science degree from Michigan State University. With that, I'll turn the program over to them.
Good evening. Thank you very much for inviting Healthgrades to share some exciting news with the board tonight. It's all very good news for those who were here last year. There's continued growth and improvement on the quality outcome side that we're excited to share. For the community at large, we did want to start and just spend a very brief minute or two giving some background on Healthgrades and just giving everyone a quick refresher on how Healthgrades approaches clinically assessing hospitals and outcomes each year. So for those of you not familiar with Healthgrades, our core is helping to empower patients with actual information that will help them in their selection of a hospital and a physician. To this end, each year we assess about 4,500 to 5,000 hospitals based on their clinical outcomes across 33 of the most common procedures and conditions. So we'll go through that in just a minute. Outside of our hospital ratings core division, we also have a robust website that's designed to help patients find and select a physician. So for the physicians in the room, I definitely encourage you to Google yourself or go to Healthgrades and look at your profile. It's got a ton of traffic. You can see there's about 500 million people a year that go on the internet looking for information on a physician or a hospital, and about 350 million of those people come to Healthgrades, so it's definitely a valuable resource. And here in the Bay Area, we just wanted to show some information about search activity on Healthgrades. You can see that across the whole Bay Area, there's a little over 3 million search. And one of the key areas is orthopedic surgery. I think that's great for the Washington team here, as we'll see in a minute. There are some incredibly powerful achievements, again, for the Joint Repair and Restoration Institute. So moving quickly into the methodology that Healthgrades employs each year. It's very much a clinically based methodology. We want to assess what's happening to patients during their course of care at a hospital and evaluate hospitals that have better than expected, worse than expected, or as expected outcomes for their patients. To get to that, we look at 3 years of Medicare patient data. So this is the most current 3 years of Medicare data available to anybody in the country from CMS. So for the data that we're going to, or the awards rather, that we're going to talk about in a minute, they tie to outcomes data from Medicare fiscal years 2013, 14, and 15. So this will cover patient outcomes through October of 2015. So it's a little bit in arrears. And then as the new information is released in the spring and summer, Healthgrades will update their awards, and those will be released next October. So what we're looking at today, we'll look at outcomes from these past 3 years, and I'm going to hand it over to Catherine to share the good news.
Thank you, David. Thank you all for having us. Once again, Washington Hospital is one of the national leaders in overall clinical excellence, named among the top 5% in the nation for that overall clinical excellence for 3 consecutive years. And you are a recipient for 2017 as well. That has not been publicly announced yet, so keep it tight. It will be announced on January 17th, but congratulations. In 2016, you were one of only 18 hospitals in the Bay Area to achieve this distinction. So congratulations. And in 2017, you were the only hospital in the Bay Area to receive America's 100 Best Hospitals for Joint Replacement for a 6th consecutive year. Congratulations to the team here at Washington. What an amazing achievement. You were also the only hospital in the Bay Area to receive the Orthopedic Surgery Excellence Award for 4 years in a row. So again, wonderful job to the team here. The only hospital in the Bay Area to receive Healthgrades Joint Replacement Excellence Award for 11 consecutive years, and one of only 3 hospitals in the entire state of California. So, wow, wonderful job to the entire team. And one of only 3 hospitals in the Bay Area to receive Healthgrades General Surgery Excellence Award for 4 years in a row. So, some wonderful achievements here at Washington.
And I'd be remiss if I didn't note that you'll see the Bay Area definition that we have at the bottom is a very expansive definition, so it fully encompasses all of Napa County. So some of your competitors up to the north are included in this, and they don't have the same level of achievements as Washington does. So some good differentiation there.
And Washington Hospital was also named among the top 10% in the nation for overall patient safety for a 2nd year in a row. So this was an achievement released in April, so 2015 and 2016, and one of only 3 hospitals in the Bay Area to receive that for a 2nd consecutive year. So wonderful news. Congratulations on all your hard work on patient safety.
Absolutely.
These are also some additional achievements here in 2017. You'll notice a lot of these are multi-year achievements, 5-star recipient in heart attack, sepsis, total hip replacement, esophageal and stomach surgery, as well as total knee replacement. And again, these are the America's Top Hospital achievements, the Distinguished Hospital Award for Clinical Excellence, again for that 4th consecutive year. One of America's 100 Best Hospitals for joint replacement for a 6th consecutive year, as well as those great patient safety achievements for 2 consecutive years. And as we look at the overall achievements through the rest of the service lines, cardiac, again, that heart attack, 5-star, and then named among the top 5% in the nation for joint replacement for 11 consecutive years. Wow. And top 10% in the nation for overall orthopedic surgeries for 4 years in a row. So again, some wonderful achievements, as well as the top 10% in the nation for general surgery for 4 years. And that 5-star for treatment of sepsis for 3 years in a row.
So we wanted to take the last few minutes with the team here and dig a little bit deeper, just scratch the surface of what's driving the ratings. So wanted to share this first few here, which gives an overall view of the quality trend at the hospital going back for 5 years. And for those statisticians in the room, this is a volume-weighted Z-score. For those non-statisticians, it's basically a volume-weighted average of all your outcomes. So it's a one-shot kind of glimpse of how your quality is doing year to year. And you'll note the red line there is indicated that's the threshold to be in the top 5% of hospitals in the nation. And as you heard, I've been with Healthgrades for several years now. this top 5% threshold has increased every year I've been with Healthgrades. And so what I see from this chart is not just a hospital that's getting better each year, but a hospital that knows it's one of the national leaders, knows it's a best of colleagues, but is still focused on increasing outcomes, improving outcomes every year. And so not just content with being in the top 5%, but really pushing to increase that gap to those other hospitals in the top tier in the nation each year. So really, really impressive, and something we'll continue to look for that positive trend to grow year over year. And then the other thing that we wanted to share, and we'll look at this for knee replacement, for hip replacement, and then for heart attack, it's a regional comparison. So there's a lot going on here, and so just want to walk you through what we're seeing. So we see Washington Hospital on that top line, and then as we work left to right, we see Medicare case volume for the 3 years, and then we see the actual complication rate. So for Washington Hospital over the 3 years, we saw a 2.89% complication rate, which is extremely low and very, very good. And then the next column, we see the predicted complication rate. The Healthgrades methodology, what we do is we compare what actually happened to what we predict would happen based on the acuity profile of your patients. So that predicted column is really something you can view as a proxy for overall patient acuity. So you get a sense of how your patients compare clinically against some others in the area and where some of those more risky patients might be going or not going. And one thing that Catherine did note, and when we looked at the historical data, is when we looked at last year's volume for the 3 years, it was just over 1,600 cases. And you can see the volume for the current 3 years is getting up closer to 1,700, 1,660. So for that 2015 year of data that was added, there was about a 10% annual increase in the case volume in total knees. So looking at what likely rolled in for 2015 compared to what rolled out for 2012, you netted about a 55 patient gain. So that's about 10%. So really good things going on the joint side of the house. And again, one of the lowest predicted rates on here, the lowest predicted rate on here outside of that one pesky hospital up north, but they're just a little bit ahead of you. But again, similarly 5-star rated. So you want to talk through hip?
Sure. Again, you'll see that this same chart with hip replacement, again, case volume 867 cases, significantly higher than any of the competitors we have listed here. The actual rate of complications, 0.69, the lowest of all of these competitors, so wonderful job.
Less than a 1% complication rate is, you can't ask for anything better than that.
Absolutely fantastic. And again, a very, very strong 5-star. And finally, heart attack, one of the lowest. Again, case volume 257, actual rate of mortality 5.45, predicted 9.98, great 5-star. We did notice that this is one of the lowest rates of mortality on this chart, beating both the state and national averages. Yeah. So,
and
wonderful
again,
job.
Just to speak to that predicted or patient acuity side, you can see that the acuity at just about 10%. You're seeing patients that are sicker on average than at the state or national level, and you're still able to drive and affect better outcomes than even those hospitals that are seeing healthier patients. So really, really kudos all around to the clinical team, to the nursing team, to the service line leadership, and the quality management and improvement teams. Because again, as I said earlier, it's not just consistent national leading outcomes, but it's seeing that improvement year over year that really speaks to the commitment of the leadership in the room, as well as the frontline physicians and nurses, and really the whole care team that's out there every day helping these patients. So from Healthgrades to Washington Hospital, the board, guests in the room, and really the whole clinical team here, congratulations, amazing outcomes, and we look forward to coming back and keep giving you better news each year. So thank you very much.
Well, thank you.
If there are any questions, we're happy to field any questions on any of this information.
Would you be willing to stand for photos with the board and the trophies?
Oh, it'd be our honor.
It would be our honor, please.
All 5 of you, please.
Okay.
get a little
Stanley Cup moment, maybe?
Just no good. That one should get
I know, I'm the short one.
it. Yeah.
I'm right there with you.
Yeah.
All right.
Congratulations, everyone.
Thanks.
Thank you very much, Nancy. Thank you, sir.
Well, I have to say, I guess I'm guilty of taking things for granted because I'm totally flabbergasted by how well we did. Congratulations, Nancy, to you and the staff and the medical staff for such great results.
I think they've worked hard at this,
Yeah.
and they've taken the patient-first ethic very seriously.
Yeah.
It shows in all their work.
Sure. Wonderful.
Very proud. Now I have a second session of education for you. Dr. Albert Brooks is our Chief of Medical Services here. I think he's well known to all of you. He came to us from Alta Bates Hospital in Berkeley, where he'd been chairman of the OB department, president of the medical staff, and then also served as a member of the board of trustees of that hospital for 12 years. He was born and raised in New York City, attended Albert Einstein College of Medicine, where he completed his residency in OBGYN. He served as the OB hospitalist director at Washington Hospital in 2004 and helped lead us to a very successful start. He streamlines our credentials and quality improvement bylaws, policies and procedures, and rules and regulations. He also serves in liaison capacity with the medical staff leaders and this administration. He's also president of the Washington Township Medical Group and is a member of the board of Washington Township Medical Foundation. He's here tonight to talk about MACRA, which is CMS's answer to the problems they struggled with the sustainable growth rate, which was supposed to provide methodology for adequate payment for physicians. And as you might recall, over the many months this was being discussed in Washington, D.C. in Congress, that was something that was like a kicking the can down the road and not really settling the problem. So this is supposed to be the answer to that for the physicians. Now, in the wake of our national elections, we're aware that the new president, will want to repeal, if he can, the Obamacare, the Affordable Health Care Act. I'm not sure what's going to happen with MACRA, but because we don't know one way or the other, and it is on the docket to be implemented pretty quickly, I thought it was tremendously important to come forward with this so that the board and the community understand what CMS is imposing on medical practitioners. So that I'd like Al to make this presentation.
Thank you, Nancy and the board. Tough act to follow. First we had good news, now bad news, MACRA. It's been estimated that about 1.2 million eligible clinicians, that's physicians, are in the Medicare program, and that's an important number to keep in mind. And of them, less than about 30% actually participate in the incentive programs. So it's to the fullest extent. So I'm just going to touch on a few highlights about MACRA. I was lucky enough to attend a conference that was held in San Francisco, put on by the California Medical Association and the Institute for Medical Quality. and the speaker was Ashby Wolf. She's the Chief Medical Officer for CMS for Region 9, which includes California, Nevada, and Arizona. And she gave a very good talk. And I actually heard her speak previously about physician incentive programs from Medicare. And she actually was a primary care physician in Oakland back several years ago, and I remember her from that time. So she gave a great talk, and I've culled a couple of her slides. So MACRA, a brief overview. As Nancy alluded to, this was the getting rid of the docs fix, which we called SGR, which it was established in 1997 to control the cost of Medicare payments to docs. And Medicare states that it's a move towards patient-centric healthcare system, but actually it shifts payment away from fee-for-service and the fee for number of services with rewarding, quote, for quality of care delivered. And this was signed by Barack Obama, as Nancy stated, back on April 16th of 2015. And it was bipartisan legislation, and I think we need to point that out. It wasn't just one party that put this in place. The Doc Fix, the SGR program, was month after month and year after year, Congress was going to cut physicians' Medicare payment by up to 25, 28% by the end. So in 2015, Obama got this law from Congress and went ahead and signed it. So just to review a little bit, Medicare payments prior to MACRA involved a fee schedule. So the stethoscope, as you see, the doctor provides a service to the patient, and there's a Medicare fee schedule. And then, of course, like any bureaucracy, there are adjustments to how doctors are paid. And then there's a final payment. And the adjustment is based on physician quality reporting, or PQRS, and value-based payment modifier. And I know, I can go through these acronyms. It isn't always helpful. Anyway, there's also something called Medicare EHR Incentive Program, and that's so-called meaningful use. So all three of these things, prior to MACRA, could play into the final payment that physicians receive on the right side of the slide. And as I said, the participation is problematic. I looked up a number of statistics around this, and for PQRS, 49% of the physicians who participate have penalties, and only 39% get incentives. And as I said, it's 30 to 40% of total people who are eligible to participate actually do it and submit this data to Medicare. There's something called the value-based payment modifier, and that's the green box. And in that area, only 61% of doctors submit data to Medicare, and 39% get penalized for not having good data. So you can see the program, it has some side of its incentive. And by the way, with that middle green button, the incentive was only given to 0.1% of the physicians who submitted data. Is this skewed or what? Anyway, meaningful use, which is the use of a computer and using a computer to contact the patient. And I should mention, value-based payment modifier is based on the treatment of diabetes, the treatment of congestive heart failure, and the number of hospitalizations and the length of the hospitalization. So it's a whole formula that only a Medicare policy wonk understands after you submit your data. And especially with the meaningful use piece on the right, we have a statistic that says about 52% who present their EHR data and usage of EHR to Medicare, 52% are penalized when they go ahead and present that because they're not using it correctly. They either bought an EHR, didn't understand how to use it, or didn't pull the right material from the EHR that they submitted to Medicare. So it's really problematic in its current state, and it needed to be fixed. And so MACRA was signed into law. After MACRA was signed into law, the Medicare at least had the good sense to ask for comments. Over 4,000 comments were put out to MACRA, about the MACRA law that was signed in. And after that, they decided, CMS decided they're going to change the law, and they had something called the final rule. And the final rule, and I have a slide on that, I'll just go forward. The final rule was released this October 14th, 2016. So law 2015, 4,000 comments, final rule 10/14/16. And now we have, quote, something that we can look up and utilize to figure out how doctors are going to be paid. And so another acronym, they call it QPP. And I want to point that out. QPP.cms.gov is currently the truth of how MACRA works. And so physicians and their employees, their managers, and their EHR providers all need to go to that site to figure out how they're going to submit bills to Medicare. So we finally have a final rule. However, I need to say there's not quite a final rule. There's a 60-day period after this final rule. So it won't be a final rule till 60 days from October 14th. So even now, people are sending comments, the American Medical Association, the California Medical Association, and they're asking for things like, you got to make this more flexible. You have to make it more able to be utilized by physicians, by large practices, by small practices. And until they do that, it's again going to be the same thing like I told you, penalties for half of the physicians who participate. In any event, let me just go back. So MACRA now has a different acronym describing what it does. And I think I told you MACRA means Medicare Access Chip, who cares? Reporting Act. Anyway, actually MACRA is the overarching name, and we're all going to be talking another acronym, and that's going to be MIPS. Because as you see in this slide, the Medicare fee schedule, it'll be adjusted by the QPP program, which is the green in the slide. And then on the left side, you see merit-based incentive payment system. So that's the new PQRS value-based management designation, okay? And we think it's estimated that over 90% of physicians and their groups will get their payment through the MIPS program, which is merit-based incentive payment system. Again, and there are going to be maybe around 10% of providers who'll get what's called an advanced payment model in their practice. And later on, I'll just show you what that means. It's not going to be for the majority of physicians. It's usually physicians who are already in an organized structure like a medical home, or they're in an ACO or a pioneer ACO, and I'm sorry to throw out all the acronyms, but as Nancy alluded to, the whole concept of Obamacare could lead to it being repealed and ACOs going away, but we don't know if that's going to happen. So which clinicians does MACRA affect? And physicians are asking me this, is it going to affect me? Well, yes, if you're an MD in this country, or you're a physician assistant or a nurse practitioner or a clinical nurse specialist, and you're submitting a bill to Medicare or a CRNA, you are going to fall under eligibility to be reimbursed through this program. The one thing we need to say is that if you bill under $30,000 a year to Medicare and you provide care for less than 100 patients in a given year, you won't have to participate in the program. It's Medicare Part B eligible clinicians, and there's the listing of the clinicians. So once again, it lists the two quality payment programs, and as I said, the one on the left is an advanced alternative payment model, and we think most of our docs, especially our docs here at Washington Hospital, will be submitting data under the MIPS program. We've already got a team of staff working on how we're going to submit our MIPS data. And just a little detail, just to show you, there's MIPS, and I should mention that if you've been under the previous program of PQRS on this slide and value management and Medicare meaningful use, those are the legacy programs in Medicare. They're going to be phased out, and the last performance period under the legacy programs will be the year 2016. And like everything with Medicare, you do work 1 year, you're not paid for 1 to 2 years. So the end of the payment adjustments for these phased out processes the payment adjustments will occur in 2018. Again, physicians usually know that it takes a while for this to hit you. And then I also should mention changes under MACRA related to quality payment programs that do not affect the Medicaid or hospital EHR, do not affect the Medicaid or hospital EHR incentive program. That program will continue. And just to point out. So, okay, MACRA to MIPS. So MIPS involved four areas: quality, cost, improvement activities, and advancing care. And I wanted to emphasize the quality metrics. I apologize. The quality metrics that most doctors report are fairly easy things that they do in an everyday practice, from doing a pap smear to ordering a mammogram to smoking cessation counseling to annual exams to controlling hypertension. So they actually have made it easy for this part of the reporting. So under quality, you can choose one of these quality metrics, or you can choose up to 4 and report them. Your cost reporting is a little bit more complicated, and you have to do that with your office manager, looking at your billings, et cetera. But you can, with some help, do the correct cost reporting along with the quality. Improvement activities have to do with things like making sure that you send the patient's information. Well, I'm sorry, I'll skip improvement. Advanced care information is making sure that you send the patient's medical record electronically to the primary care physician, or the results of a test, or the after-visit summary. And improvement activities are patient engagement, and making sure that you utilize some electronic system to engage patients. We here at Washington Township Medical Foundation, we have our doctors use MyChart, and just by reporting that we use MyChart, you qualify for an improvement activity. And I'll go a little along and show you that this is actually a simpler reporting than we've had before. And most of the American Medical Association, the California Medical Association, and MGMA have all said that this final rule with MIPS does actually clarify it a little bit and makes it a little easier to report. Not perfect. So here comes Medicare again. Now, when you do this MIPS reporting, there's going to be a weighting score attached to what you report. And you get a 60% in the green if you report quality. So the quality parameters give you more weight to getting a bonus and not getting a penalty. So it's a 60% weight. Advancing care information is a 25% weight in the blue, and the red is in improvement activities, around what I've just described, what each one of these are. Again, it gets complex, but welcome to the government. At the end of the day, this is the money slide, because you always want to get to it. How much can MIPS adjust payments? And this is a great illustration. So you start reporting in 2017, and then you see in 2019, it's plus or minus 4%. They calculate your billings, they see how the weighted score goes, and they decide whether to ding you 4% or give you a bonus of 4%. And then the next year, 2020, it's 5%, then it's 7%, then it's 9%. It's the system, it was developed, it's been vetted, it's been looked at by many, many experts, and the feeling is it has to be done because we're trying, ultimately Medicare is trying to not have their cost curve continue to rise and try to lower the cost of caring for Medicare beneficiaries. We're almost done. Anyway, the timeline for this quality program, the reporting starts as of January 1, and it runs through October of 2017. Which, to Nancy's point, is we've got to get ready for this. We're getting ready in the foundation because the clock is ticking. I should mention they're giving you these 3 choices during this year, the beginning year. And a lot of experts feel this at least shows some flexibility. So on the left side, you see, you submit some data after January 1st, 2017. If you do that, and the operative word is some, it's neutral or a small payment adjustment, okay, whatever the data is. If you report for a 90-day period after January 1st, 2017, there's a small positive payment possibility because you're doing it for a set number, 90 days. And if you have a full participation starting January 1st, 2017, they describe it as a modest positive payment adjustment, back to what I said, the 4%. And this is some flexibility for doctors getting to choose how much they want to participate in MIPS. Because remember what I told you, only about 40% in the current program participate. And this is the incentive to get more and more practices to participate, especially small practices that can't collect a lot of data quickly or may have limited resources. And in fact, in this law, there is a way to get help to small practices, onesie, twosie doctors, or even doctors in rural practices. And I should mention on the slide, always read the fine print. Down at the bottom it says, not participating in the quality payment program for the transition year will result in a negative 4% payment adjustment. So if you're a Medicare provider and you don't give them any data, say hello to negative 4%. So there is now also something called choosing to test for 2017. And instead of reporting six quality measures, you can actually choose to test for 2017, and you only report one quality measure or one improvement activity. Or you can even report 5 required advancing care information measures, and that has to do with your electronic record. If you decide to test, you can avoid a reimbursement penalty in 2019. So if you test for the 2017 under one of these ways to test, you can avoid that 4% penalty. So that's being emphasized both at CMA and AMA for doctors to try to understand. You can't hide if you're a Medicare provider, and again, as I said, more than $30,000 a year to Medicare, and more than 100 Medicare patients, which, by the way, the majority of physicians who see Medicare patients meet that, so they have to participate or they're going to get the 4% hit. Again, the partial participation for 2017 is the 90-day, and with that, you only, again, one quality measure, one improvement activity, or the 5. And if you're not ready on January 1, you can choose to start any time between January 1 and October 2nd. And you have to send the performance data by March 31st, 2018. So you can collect it, but you got to send it so you have time. And of course, full participation, I alluded to earlier, that's where you can earn the most positive, and you have to participate fully. And payments are based on the performance data submitted, not the amount of information or the length of time submitted. So one point I should make, there are groups of clinicians who will not be subject to MIPS, and that's doctors who are in their first year of Medicare Part B participation, clinicians, I should use that term because it covers non-physicians as well. Below those docs and clinicians below the low patient volume threshold, and then certain participants in the APMs, that's the Pioneer ACO model. And I should, at the bottom again, bottom small print, MIPS does not apply to hospitals or facilities. Remember, this is about physician and clinician providers. And I mentioned alternative payment models, and I thought it would be useful to just show you this one slide. This is where around the country alternative payment models are currently in place. And you notice there's a little skewing to the right, if you will, in terms of APMs. And the APMs, I'm going to skip this because it just says that they get a 5% lump sum incentive in all of those places I showed you. And examples of APMs are shared savings programs. You may have heard of that. Or the next generation ACO model. There's something called an oncology care model. Again, that's an advanced payment mechanism through MACRA, and you don't have to participate in that MIPS that I showed you. Comprehensive end-stage renal disease care model. there are organizations doing that, again, a lot on the East Coast, more on the East Coast than the West Coast. And you can find a list of the advanced APMs, again, at qpp.cms.gov, and they're going to be updating that. And this slide just addresses that there are future advanced models, and there's actually physician groups working on, there's a so-called Physician-Focused Payment Model Technical Advisory Committee, or a PTAC, to review and assess physician-focused payment models. And there are people kind of coming up with new models of care, looking for ways to take advantage of APMs and get that 5% bump. But again, you're going at risk when you participate in some of these APMs, even as a clinician provider. And again, this just alludes to what I talked about, end-stage renal disease oncology care model and the next generation of an ACO model. Again, describing that we have that. I mentioned earlier there are some parts of this law that allow small practices to get free training and how to qualify for it, and it reduces their time and cost to participate and provides an on-ramp for them to participate. So we ask that small practices really need to take a look at it, especially in rural and underserved support areas. It can help you, especially when there's a shortage of professionals in that area. Again, there's a lower volume, and it's designed for that group that does less than $30,000 a year to Medicare, et cetera. And they only have a few items that they have to present. So, as doctors say, what do I do now? First off, when you've got to check between now and December to make sure CMS is trying. They've said that they will be contacting the 1.2 million I told you about to get them ready and get the data started. The expectation is that once your staff, your manager, and if you have an electronic record in your office, it will really help you gather the data. There's an NPI lookup tool available on the Quality Payment Program portal, and in January of 27, you've got to go ahead if you want to and start submitting the data through that. I should mention here that I had a chance to talk to Ashby Wolf, the Chief Medical Officer, and she has promised me that she will come and talk to our medical staff directly about this and give you much better details and a better presentation than I could do at all. And you can call 1-866-288-8912, and you can actually find people over the phone. Someone picked up the phone. I tried it just to test. And also, as I said earlier, qpp@cms.hhs.gov if you have questions.
Wow. Thanks a lot, Dr. Brooks.
Sure.
Any questions?
I know. MIPS, MACRA.
I thought it was a very good presentation.
I have a question now.
Sure.
With the presentation by Dr. Wolf, did she comment as far as what the expectation is as far as how it will affect participation by physicians in Medicare? Because there are parts of the country where there is decreasing Medicare participation rates.
Yeah. That was one of Dr. Nicholson. That was one of the early questions. Was how's this going to affect participation? And she said that in some areas, again, she didn't tell me where exactly, but she said in some areas it actually drove up participation. Once they realized there was a way for them to see a bonus, and it was mainly in the APM kinds of areas where there's a model to get you that 5% push right away, sooner than later. And so they say they expect greater participation, certainly better than 30 or 40% in some areas. We'll see.
Thank you.
Thank you, Dr. Brooks.
Okay.
Okay. We are going to move now into the consideration of the minutes of the October meetings. Can I have a motion for that?
So moved, Mr. President.
Second.
Okay. Dee, would you please take the roll?
Director Wallace,
Aye.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Danielson,
Aye.
and Director Epen.
Thank you. Motion passes. Okay, we're going to move into any oral communications. Are there any oral communications tonight? Seeing none, we'll go on to written communications. Dr. Tsoi?
Thank you. We'll go over the credential action items. The first is new appointments. We have 4. Dr. Irene Beisner, OB hospitalist. Dr. Kissing C, urology. Kui King Huang, pediatrics. And Helen Wong, internal medicine hospitalist. Under reappointments, we have Dr. Michael Bostich, radiation oncology. Dr. Ashwani Bindal, internal medicine. Dr. Kwanchan Chen, cardiology. Dr. Murali Dharan, cardiothoracic surgery. Dr. Asal Dokoshiva, pediatrics. Dr. Katerina Guzman, internal medicine hospitalist. Dr. Nancy Hua, internal medicine. Dr. Soham Javari, internal medicine. Christina Lee, pediatrics. Dr. Connie Lee, internal medicine. Dr. Brian Lipson, allergy immunology. Dr. Diane Martin, infectious disease. Dr. Kevin Morrissey, emergency medicine. Dr. Norma Paragas, pediatrics. Dr. Shaista Shah, internal medicine. Dr. Rajesh Suri, cardiology. Dr. Ramesh Viraganham, cardiothoracic surgery. Dr. Stephen Watt, oral and maxillofacial surgery. Dr. Richard Wright, otolaryngology. And Dr. Stanley Yu, gastroenterology. Under completion of proctoring and advancement in staff category, we have PA Melanie Castro, Dr. Harman Chawla, Dr. Manuel Lam, PA Benjamin Lee, Dr. Ryan Padres, Dr. Sarab Sethi, and Dr. Kevin Yee. Under completion of proctoring, prior to eligibility for advancement in staff category, we have Dr. Mingzu Stein. Under extension of proctorships, we have Drs. Bonilla, Dr. Brook, Dr. Kukalis, Dr. Cooper, Dr. Espirito, and Dr. Obayashi. Under new privilege requests, we have Dr. Ahmed Sadiq, hematology oncology for hospital and palliative care. And under deleting privileges, we have Dr. Ashwani Bindal for internal medicine procedures, Dr. Chen for EP procedures, peripheral angiography, and peripheral vessel stent. Under Dr. Soham Javari, is giving up internal medicine procedures. Dr. Connie Lee, giving up internal medicine privileging. Dr. Shaista Shah, giving up pap smears, endocervical culture, and CCU level 3. And Dr. Richard Wright, giving up liposuction procedure for contour restoration, head and neck only. Leave of absence, we have Dr. Frederick Wilson. And under resignations, we have Dr. Patrick Duffy, Dr. Ethan Nichols, RN Christine Skolnick, and Dr. Stacy Soul.
Can I have a motion for the credentialing, approval of the credentialing action items?
Mr. President, I move for approval of the credentialing action items as presented by Dr. Choi.
Thank you.
Second.
Thank you. Dee, please.
Director Wallace.
Aye.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Aye.
Director Epen.
Aye.
Motion passes. Thank you. We can now move to the Service League report. Happy birthday, Debbie.
Oh, thank you.
Yeah.
Thank you very much.
Good
It
to
was
see
a
you.
really nice day. Service League is hitting the road running. We were participated in the Think Pink event, which was wonderful. We had a lot of people coming to our booth, and I'd like to thank Jeannie Yee. She did a wonderful job of putting together these really precious high heels. And basically what the theme was is volunteers land on their feet. And we had a lot of traffic coming by, a lot of questions, and hopefully get some more volunteers. As well as Gail Tomika and Marina Fleming, they were also there for me, and Cherie Gramado. It was really nice. It's a beautiful event, too. I really look forward to being a part of it. The other thing that we are getting ready to, or I'm really getting ready for, is the Gift Shop Holiday Show. It's going to be on Monday and Tuesday, the 14th and 15th. And we hope you'll stop by. I have lots of new merchandise coming up. We are going to be closing the gift shop on Saturday and Sunday so that I can get ready for it, because it's just too hard when people are peeking through the window at me. So that'll be nice, and I'm looking forward to doing it. It's been a lot of fun, I mean, a lot of work, but it's a lot of fun. And the people have just been really receptive, and they're looking for it, because I won't give any secrets away ahead of time. The other thing is that we are going to be having our masquerade jewelry sale. That is going to be the Monday, Tuesday, Wednesday after Thanksgiving. I mean, I can't even believe we're talking Thanksgiving already. And that'll be the 27th, 28th, and 28th, 29th, and 30th, excuse me. And it will be in all three of the rooms here this time. So people have more space, it won't be so crowded for checkout and everything. I think it'll work a lot better. It's our first time doing it, and I'm hoping it's going to be a great success. And Cherie is working tirelessly to always make this a great success. So please come. And flyers are all over the place. We're doing our best. Now, the last thing that we are in the middle of starting is I really wanted to do something for the Service League to give back to the community. So this year we are going to be doing a toy drive, and it's going to benefit the children of SAFE. And so what we're doing, there's been a flyer right there for you to look at, and there are flyers around the facility. And we really want to focus on, for the children under 12 and under, the toys and games and books and even socks and underwear and PJs. Things of that nature. But for the older kids up to 18, we'd like to focus on gift cards from like, say, Target or Walmart, something that's easy for them, because we want them to be able to buy what they would like, but something that would be special to them. And we are having location drops in the Service League office as well as at the gift shop. And if the gift shop is not open, which sometimes it's not, Brenda at the front desk in the lobby and Dee are going to be been so gracious that they will take care of it for us, and then when they get done with their shift, they will have security put it into the gift shop. So that'll make it really nice so that people can do that. And we hope it to be a great success. And this is the first time we've done that. And just giving back to our community, and that's what it's all about, isn't it? So that pretty much summarizes what we've been doing, or what we're going to be doing as well.
This is a busy time of year.
Yes, it is. Very busy time of year.
Yeah. Any questions, anyone? Thank you, Debbie.
Thank you.
All right, Dr. Tsoi, back to you.
So I'd just like to report that there are approximately 589 active medical staff members on staff at this time.
Thank you. Thank you. Nancy, the calendar,
We'll do
please.
the calendar. Let's go ahead with the video.
Past health promotions and outreach events. On Thursday, October 13th, Washington Hospital hosted the annual Think Pink Breast Health Awareness event. The event featured a health fair and presentations by Dr. William Degoni, General Surgeon and Medical Director for the Washington Women's Center, Lori Raffelson, Registered Dietitian, and Dr. Vandana Sharma, Oncologist. The program also featured Tai Chi and meditation activities. Dr. Victoria Leapart, gynecologist, moderated the event. Over 250 people attended. On Wednesday, October 19th, 26th, and November 2nd, Dr. Victoria Leapart, gynecologist, presented Restoring Balance, a 3-week stress reduction program. 10 people attended. On Thursday, October 20th, as part of the Women Empowering Women series, Dr. Victoria Leapart, gynecologist, presented Keeping Your Brain Healthy. 12 people attended. On Thursday, October 27th, Glenmore Elementary School in Fremont hosted a student health fair. Washington Hospital staff provided information on proper hand washing and hygiene to prevent infection and the spread of germs. Over 500 students attended. On Saturday, October 29th, Washington Hospital screened 121 people at the abdominal aortic aneurysm screening. These aneurysms develop over time and may have no symptoms. However, if one bursts, it can cause immediate and life-threatening symptoms. Dr. Ash Jain, cardiologist, and vascular surgeons Dr. John Thomas Mahegan and Dr. Gabriel Herskew interpreted results from the Doppler screenings. Of the 121 screened, one was found to have a possible aortic aneurysm. A special thank you to Fremont Bank for co-sponsoring this screening. On Wednesday, November 2nd, the Washington Community Health Resource Library, in collaboration with nursing students from Samuel Merritt University, hosted a health fair at Cottonwood Place Senior Apartment in Fremont. This event was organized as part of the nursing students' curriculum to complete the Support of Community-Based Clients course. This course provides students with skills to organize health screening and assessment functions to promote well-being to clients living in the community. The nursing students provided an overview of osteoporosis, and the Community Health Resource Library provided bone density screenings. 31 people were screened. Also on Wednesday, November 2nd, Washington Sports Medicine provided a sports physical clinic for high school student athletes. The physicals were held at Irvington High School, and athletes from all local schools in Fremont were invited to participate. Each student received an assessment and physical to ensure they meet the California Interscholastic Federation requirements in order to play sports. Doctors Russell Nord, Michael Golden, and Stephen Zahner provided the examinations along with help from certified athletic trainers from the Washington Sports Medicine program. 71 students received sports physicals. On Friday, November 4th, the Washington Hospital Sports Medicine program provided athletic trainers and hosted a first aid booth at the Tri-City Area Special Olympic Soccer Tournament held at Maloney Elementary School in Fremont. 347 people participated. On Wednesday, November 9th, Dr. Jason Chu, pulmonologist, presented Respiratory Health and Lung Cancer Prevention and Detection. 18 people attended. Upcoming health promotions and community outreach events. On Thursday, November 10th, from 6 to 8 p.m., Washington Hospital is hosting a special community forum where Leslie D. Michelson, author of The Patient's Playbook, will present Finding the No Mistake Zone, Lessons from the Patient's Playbook. At this free talk, Mr. Michelson will share life-saving strategies and decision-making tools that you and your family members can start using now to become more savvy healthcare consumers. A book signing will occur immediately following the forum. For questions, call 1-800-963-7070. Also on Thursday, November 10th, the Washington Hospital Sports Medicine program will provide athletic trainers and host a first aid booth at the Tri-City Area Special Olympic Soccer Tournament. The tournament will be held at American High School in Fremont. On Saturday, November 12th, from 8 a.m. to 1 p.m., Washington Hospital will host the 8th Annual Diabetes Awareness Health Fair. The event will feature a health fair and presentations by Dr. Jack Meyer, endocrinologist, Dr. Stephen Zahner, family practice, and Anna Mazet, registered dietitian. To register, call 1-800-963-7070. On Tuesday, November 15th, Washington Hospital will conclude the Family Caregiver Educational Series. This 6-week comprehensive series offers resources and strategies for family caregivers to provide quality care for their loved ones. Michelle Heading, RN, Spiritual Care Coordinator, and Father Jeff Finley, Palliative Care Coordinator, will present Loss, Grief, and Recovery. On Tuesday, November 16th, from 1 to 3 p.m., Maggie Gooding will be providing a healthy holiday cooking demonstration. On Thursday, November 17th, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart, gynecologist, will present Mindful Eating for the Holidays. On Tuesday, December 6th, from 6 to 8 p.m., as part of the Stroke Education series, Dr. Ash Jane, cardiologist, and Melissa Reyes, RN, will present Acute Management of Stroke, Chronic Care, and Stroke Rehabilitation. On Wednesday, December 7th, from 6:30 to 8 p.m., as part of the Washington Sports Medicine and Washington Outpatient Rehab Center bi-monthly education series, Dr. Russell Nord, orthopedic surgeon, will present Why Does My Shoulder Hurt? Shoulder Pain in the Youth Athlete, to the weekend warrior and beyond. The Washington Hospital Healthcare Foundation report. Washington Hospital Healthcare Foundation is preparing for the annual Trees of Angels celebration, which raises funds for hospice and palliative care. Please mark your calendar and be sure to join us at one or more of the following events. Holiday tree lighting at Bernardin Family McDonald's at the corner of I-680 and Mission Boulevard on Monday, November 28th at 6 p.m. Holiday tree lighting at Washington West, 2500 Maury Avenue on Wednesday, November 30th at 5:30 p.m. Holiday tree lighting at Newark City Hall, 37101 Newark Boulevard on Monday, December 5th at 6:30 p.m. Holiday tree lighting at Union City City Hall, 34009 Alvarado Niles Boulevard on Friday, December 9th at 5:30 p.m. For more information about these events or to inquire about sponsoring Trees of Angels, please call the Foundation at 510-791-3428. The Washington Township Healthcare District Board of Directors report. In the past month, District Board members represented Washington Township Healthcare District on Saturday, October 22nd at the Night Fever Dinner Dance hosted by Safe Alternatives to Violent Environments. They also attended the Masonic Homes of California's ribbon-cutting ceremony for its transition short-term rehab facility on Tuesday, October 25th, and the Union City State of the City Address hosted by the Union City Chamber of Commerce on Wednesday, October 26th. Washington Hospital Employee Association, WIA. WIA held the 2016 Drive for Warmth clothing drive from October 17th through October 28th. 9 barrels of warm clothing items and blankets were collected to be delivered to the Tri-City volunteers to be distributed throughout the community. Washington on Wheels, WOW, Mobile Health Clinic. During the month of October, the Washington on Wheels Mobile Health Clinic, WOW, continued to serve community members at the Fremont Family Resource Center, the Fremont Senior Center, and the Ruggieri Senior Center in Union City. WOW also provided occupational health services, including influenza vaccines at Columbus Foods, a producer of fine foods, Mishuho OSI, a medical device company specializing in surgical tables, Boehringer Ingelheim, a pharmaceutical company, and AER Worldwide, a solution company of e-recycling, IT asset management, data security, and value recovery. These companies are located in Fremont, Union City, and Hayward. On Wednesday, October 26th, WOW attended the Fremont Alameda Alliance event. WOW provided 50 free flu vaccines to community members. The total number of community members receiving health care from the Washington on Wheels Clinic during the month of October was 297. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The most viewed web pages include Employment, About WHHS, Physician Finder, Volunteers, and Women's Health and Pregnancy. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the total number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a newsfeed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of October, Washington Hospital's cable channel 78 InHealth captured new programming, including a health and wellness program titled Obesity, Understanding the Causes, Consequences, and Prevention, and a sports medicine program called Nutrition and Athletic Performance. In addition, InHealth aired a Diabetes Matters program named Monitoring Matters, a sports medicine program called Big Changes in Concussion Care, and the October Board of Directors meeting. Awards and recognitions. Washington Hospital's Food and Nutrition Services received special recognition from Alameda County Food Bank for their donations between July through September of 2016. Washington Hospital's contribution provided the equivalent of 1,569 nutritious meals. Alameda County Food Bank expressed their gratitude for being a crucial part of the work to meet the hunger needs of the community. On Saturday, October 22nd, Safe Alternatives to Violent Environments, SAVE, awarded Washington Hospital the Excellence in Community Partnership Award. The hospital is a long-term supporter of the SAVE organization and was recognized with this award for its unwavering dedication and compassion to those SAVE serves. For more information on any of the programs mentioned, visit whhs.com or call 1-800-963-7070, and please follow us on Facebook and Twitter.
It's my privilege now to introduce you to our Employee of the Month for November. This is Raj Virinder Sandhu. She's a senior clinical lab scientist in our clinical lab in the ambulatory care division. She's much valued by her peers, clearly, or she wouldn't have been nominated for this. Her knowledge, integrity, compassion, and patience, as well as her dedication and her friendly nature, makes her a perfect candidate for the Employee of the Month award. She joined Washington Hospital in 1996, and for 20 years, she's been a pillar of the department. Patricia, the Director of Laboratory Services, describes her as a dependable team player with a let me help you with that attitude. She's also a devoted mom and balances work and raising a beautiful, smart daughter who's currently attending Duke University. We'd like to offer our congratulations to her. Before we finish, I wanted to introduce something a little bit new to the Board of Directors that I hope becomes something that we do every year. We're going to be recognizing veterans this year. And every year that commemoration day.
What I wanted to do with my life.
Oops.
And
Hey.
I wanted to
We've been feeling that we're missing a chance to say thank you to people who work at Washington Hospital who have given this kind of service to our country. And so we are making some changes in our calendar and adding this. We're also going to be moving the display honoring veterans from the alcove by the stairwell in the front hall of this building to the lobby in front of the second set of elevators farther down the hall, where there's a little bit better opportunity to display our recognition. Historically, deployments to active area of conflict were few and far between for our service members. However, with today's smaller military force, soldiers are often deployed on multiple occasions, and we want our employees and physicians who serve to know that we will support them and their commitment to service regardless of the number of deployments. And so this year we are highlighting our veterans in a short video, and on Friday, Veterans Day, we will unveil the permanent wall of recognition that honors our employees and physicians who have served or are currently on active duty. And I hope that you'll be able to join us at that unveiling. To those who have served, I want to thank you for your sacrifice, your dedication, and the family hardships that can be associated with military service. And we're honored to have you as part of our Washington Hospital family. And now we can have the film. Every year on November 11th, we celebrate Veterans Day, a day set aside to celebrate and honor those who have served our country. We are proud to carry on this tradition by recognizing those members of the Washington Hospital family who have served in the armed forces.
I enlisted in the armed forces because I was lacking direction out of high school and I needed a place to find myself, so to speak, a place to learn, be responsible and accountable.
I think in the time when I went in the early 60s, it was the thing to do. I think it was a young fellow. I didn't know what I wanted to do in life. I was in college and didn't know where to go and no direction. So the service provided some structure and new directions.
Well, when I was about 18 years old and I was getting out of high school, trying to figure out, what I wanted to do with my life and where I wanted to go, I knew that I wanted to go to college and that was really important to me, but I also didn't have the resources to go to college. So I thought it was a good place to start and go and get money for college.
I enlisted in the Army because I was unsure what I wanted to do at that point in my life, and the Army gave me that opportunity to be trained, and I still, to this day, am a biomedical equipment technician because of the training that I received from the Army.
I originally enlisted in the Armed Forces back in 1980 because I was 17 years old, no jobs around where I lived at, small town in Northern California, and interest rates at that time had jumped up and there was nothing available. So I went and joined the military and made a career out of it.
I think it's always been my dream when I was growing up to join the military. And at first I was thinking of joining these special forces, but because of my belief in preserving life, I was thinking, well, I still want to join the military, but not in the combat aspect. So I thought, well, maybe the Air Force would be ideal because we're mainly a support group.
I enlisted in the Navy as a way to get trained in the medical field, and it sounded like a great opportunity to get a good experience and learn a trade, really.
I was in the Navy. I was in 4 years active, 20 years reserve, and I was stationed on a destroyer out of Mayport, Florida, DD 942 USS Bigelow. My whole goals were to spend 30 years in the military because I grew up in the military.
I'm Dr. Robert Pipkin. My rank when I was in the United States Army was captain. I spent 1 year in the Mekong Delta with the 9th Infantry Division. You're eligible for the draft as a physician up to age 35. And one of the last things I thought that I didn't want to happen to me was to be drafted, say at age 28 or 29, midway through my residency, and have to interrupt my residency at that point. And I was sent down to a place called Dong Tam, which was a base camp of the 9th Infantry Division on the Mekong River. That 1 year in Vietnam changed my attitude about myself and my future more than any other year of my life. There's no question about it.
Serving in the military taught me a lot of things. It taught me a lot about honor. It taught me about discipline, respect, pride in doing a good job. And I just learned so much being so young and growing up in the military under that kind of discipline and that kind of responsibility.
Serving in the military gave me, as a young person, a lot of discipline, a lot of patience, understanding, gave me a value for equality.
The rewards for serving in the military were multiple. I learned responsibility, I learned accountability, I learned a great skill that I could use in the civilian world.
To me, serving in the military, I think that's where my critical thinking for nursing started at. And because I was in a Green Beret, and it's a lot of critical thinking there, on the move. I think that's what helped me out a lot, was the military and on those lines. You meet a lot of people, no matter where you go. You meet and you learn about different cultures. And I believe that helps me out a lot.
What did joining the service do for me, the Air Force do for me? It kind of helped me to mature in life. the maturity in a mental aspect, physical aspect, and it gave me a perspective that I am definitely blessed being in a country like the United States, the freedom that it offers me, and I wanted to protect that freedom.
I would not have the job here at the hospital because I would not have all that education if I hadn't joined the military. So the military was very good to me for education, and certainly the hospitals benefited by the education that I got through the military. So it kind of worked both ways.
I think it's an important part that the hospital recognizes the people's commitment, and I've seen several employees who, since I've worked here, who've been called to active duty, and the hospital has stepped back and actually supported them. And that's rewarding to them because they have families they have to support, and knowing that the Washington Hospital is behind them and there to support them makes a big difference.
I think it's great that they extend benefits for people that get deployed. I was actually here at the hospital when I got deployed the second time, and I was gone a year and a half, and I got to use some of the benefits, and I'm grateful that they hire people that are veterans and understand how, there's a lot of experience and leadership there.
Back in 2009, I was deployed to go to Kosovo. While I was in the process of having that happen, the hospital extended me several benefits which put my mind at ease. Having those benefits extended to me told me that Washington Hospital cares about its employees, and especially for the veterans that have to serve their country. That really helped me get through the experience.
The veterans deserve some recognition, and for the whole country to set aside a special time date so that I can say, yes, I donned that uniform and I served my country, and to be able to set aside a date to honor people like me and the rest of the veterans around the country, it's wonderful when that time of the year comes.
This country was built upon people who served to protect what we have today, and that is still there with veterans or people go in the service today. There's a pride in supporting your country that just can be overwhelming to you.
I don't think veterans get enough respect throughout the United States. If you haven't been in the military, if you haven't been around the military, if you haven't studied the military, I think you kind of forget how important the military is to keeping the United States stable. The military is the last line before other countries or other areas come in and invade us, or at least try to change our way of thinking.
Well, it's important to honor our veterans because, as I said, it reminds us that there are those who sacrifice a lot for the freedoms that we enjoy. And I think our country as a whole has had a variety of responses to our veterans when they've returned. Over the last few years, you've seen a really big shift in that. We've been able as a nation and as our hospital to honor those persons that serve and continue to serve even when we don't agree with the mission.
We've had many, hundreds of thousands of young men and women who have sacrificed their lives for this country. And I think it's really important that we recognize those people and remember them for what they've given to this country, the sacrifices they've made. Our country is in a position where we really are the main defender of freedom, of the various freedoms throughout the world, and it's good that we recognize the sacrifices that our veterans have made.
We greatly appreciate the sacrifices made by the men and women of Washington Hospital who have served our country at home and abroad. Thank you for your selfless dedication to our country.
Very touching. Thank you. We are going to, where are we now?
We are.
Presentation of the Lean Certification Program.
The lean, where are we on the agenda?
I think it's a presentation of Lean
Yes.
certificates and
Yes, we have certificates. So, Mr. President, if you'd like to join me up here.
Yes, I'm very proud to announce that we have 4 people that are going to be receiving this evening Lean Leader certificates. As you know, it's really important on our Lean journey that we have individuals throughout the healthcare system who are certified, because they will help to promote activities in Lean and also to help train others in the Lean methodology. So just in terms of, before we make the presentation, there are a couple of things just that we all understand that Lean certification is a 12 to 18 month process and requires proficiency in the concepts, and everybody is also evaluated in the performance of the Lean concepts. There are other requirements. We have 8 full days of classroom training, participation in a value stream analysis workshop, and a Kaizen workshop, and then you also have to be a team leader and a workshop lead for Kaizen events. And so tonight I am very honored to recognize 4 of our individuals in the healthcare system, starting with Michael Platzbecker from the Emergency Room Services. Come on up.
Come over
You
here.
have to come over there.
First things first. Thank you. Thank you. This is also your pen. Thank you. Okay.
The next is Jimmy Chang, RN from Nursing Services.
Congratulations, Jerry.
Thank you, Jimmy. Here's your pen. Okay.
Next is Michael Rogers, ATC, and also from Ambulatory Care Services.
Congratulations, Mike. Thank you.
Congratulations. Thank you. Here you go. Here's your pen. Thank you.
And last is Kimberly Alvari from Food and Nutritional Services.
Congratulations.
Thank you so much. Here's your pen. Very good.
Thank you very much.
Okay, are we going to have any presentation about Lean, or is?
Oh, no, that was it.
That was it, okay. The construction report then?
So the construction report for November. We are only talking now about the Hyman Pavilion since we've put this, last month was our last report on the garage. That job is completed and operational. On our Hyman Pavilion, as you can see from the schedule here, we're still moving along as anticipated and on time. I think our actual date is something like we're running 7 days or 8 days behind schedule, but we have a certain amount of float in there because we have rain days and things like that, so we're still very much on schedule without having any problems there. This gives you a shot of the building that you may not have seen because it's the part of the building that's facing the garage, but you can see that the glazing and glass framework is going up and is close to complete there in the back side of the hospital. It's also going on, if you see there, you've got so the wall is also going, this is on the east side of the building, which is facing Bart Way, so they've started to put the skin and windows on that side of the building, as well as putting in louvers. There's a big intake wall there for the HVAC system. This is the part of the building that is facing actually the hospital and the existing emergency room, and you can see the structure going in up here for the glass and windows as well. This gives you an idea that drywall is going in the basements. This gives you a little bit look at some of the structure going in the data room and computer server room in the basement. Drywall has started on the first floor. And we've got additional infrastructure moving forward now on the second and third floor. So if you would go through the building, it's most advanced in the basement, then second on the first, and third is the least completed of all the spaces. But here you can see we've started to put electrical equipment on the third floor, and you can see studs and things going on in there as well. So it's moving along as planned and as scheduled. You can see the skin going on here, skin going in on over here. Here's your windows that you just saw being put in. So moving along, the skin is moving on a little bit slower than we anticipated, but the waterproofing is now pretty much done throughout the whole building. So we're in pretty good shape for the winter. Okay. You can see our time frame has remained the same. Any questions?
Questions? I think it's just the piece that you had about Veterans Day brings to mind in connection with the Morris Hyman Pavilion that Morris was decorated war veteran in World War II, fighting in Metz, France, the Battle of the Bulge, where he actually was awarded the Silver Star for his valor, and I think that's only one level down from the Congressional Medal of Honor. So I know he'd be pleased with the progress that you're making and at the pavilion. Thank you.
Thank you.
Okay.
For the quality report, we have Dr. Diane Martin here this evening, and she became a member of our medical staff in 1984 and has served as chair of the Department of Medicine from 1993 to 1995. She's performed many leadership roles at the hospital, including chair of the Clinical Evaluation Committee, which includes pharmacy and therapeutics and infection control. She's been a physician champion for our 5 Million Lives campaign, where she analyzed data and educated her peers on infection control issues. And at that time, it was specifically MRSA. She attended medical school in Charleston, South Carolina, after which she completed her internship and residency at the University of Kentucky School of Medicine. She received a fellowship in infectious diseases at UC Davis School of Medicine. She serves on the board of directors of Life Elder Care and also is a member of our medical foundation. Dr. Martin.
So one of my favorite topics to talk about flu. So mostly influenza is regarding a specific virus infection. And most of us, when we talk about flu, we talk about a whole spectrum of things. And when you talk about a germ, people know what you're talking about. When you talk about flu, people automatically know what you're talking about. But specifically, what I want to talk to you about is influenza and influenza virus infection. So oftentimes flu is considered with upper respiratory infections, it's just all lumped together, but I want to specifically talk about influenza. Our influenza season is October to March, can be as late as April or May, depending on seasons. And you may remember a couple years ago, we had an outbreak very late into April and into May of the H1N1 virus, which was very devastating for a lot of people, especially children and middle-aged adults that were overweight and diabetics. Majority of people become ill and not seriously ill and recover, but it can be devastating for people who have other comorbidities, such as cardiac disease, diabetics, renal failure, cancer and chemotherapy patients, and also children, elderly, and pregnant women. The majority of people will get well within about a couple of weeks, but we can have up to 3 million hospital days based on just influenza alone and 31 million outpatient visits. So you can see it's pretty widespread. Influenza is highly contagious. It's spread mostly by touch, but also aerosolized. So many of you may have seen the cough that's backlit, and you can see the spray that comes from a cough. Well, all of those little droplets contain the virus for influenza, and that's why it's so highly contagious. So you can also get it from touching objects, touching your face, and so we encourage people to do my favorite thing, wash your hands. So the board of directors have little prels, so you can be very compliant and wash your hands. Symptoms are very nonspecific, so fever, chills, sweats, cough, and body aches, and fatigue, congestion. Complications that come along with this are secondary bacterial infection. Many times people get an upper respiratory infection, but because they become ill, they can get a secondary bacterial infection, so we have to look for that. Pneumonia is a very common complication, especially the pregnant women and our immunocompromised patients to get pneumonia. They can get neuromuscular complications, which we coined the phrase Guillain-Barré. That can affect motor function, and some patients even end up on ventilators because their motor function is so weak. It can affect cardiac problems. The virus can affect heart muscle and also result in a lot of hospitalization, and some people actually die specifically from influenza, which is a travesty since it is so preventable. The influenza vaccine is not 100% protective, but does a lot to protect, even though the matchup from year to year changes. We look for the matchup to be about 60%. Right this year, we're ending at about 50%, so we think we have very good matchups for this year. So a lot of people hold off because they say, well, the influenza is not 100%, it won't protect me. But it does help in many ways, and also protects you in terms of your getting infection and passing it on to your family. So if you protect yourself, you're gonna also help the rest of your community. So CDC recommends that we get the virus and a vaccine done annually because the virus does change from year to year. Anyone 6 months and older should get the vaccination. People that we think probably should not get vaccination are people who have had a history of Guillain-Barré. Guillain-Barré can come just because of the virus infection, but many times the vaccine can also produce the Guillain-Barré syndrome. So if a patient or a family have had history of Guillain-Barré, then we do not give the vaccine, but that's the major contraindication. Again, risk is highest in adults, so anyone 65 and older, especially if they have other comorbidities such as heart disease, kidney disease, asthma. Children over 6 months of age, we want them to get the vaccine. Moms who are pregnant and get the vaccine can protect their children because of the antibodies passed on to the children up to 6 months of age. So moms who are pregnant, we really encourage them to get vaccinated. They will protect children in that very short window. So babies are generally healthier for moms that do get the vaccine. So why do we need the vaccine every year? Because it does change. There's a mutation in the viruses from year to year. We call it a drift, which changes a lot based on certain factors in the environment. This year, not so much. We still have the H1N1 virus that's the same in this vaccine that was in last year. So we suggest everyone get the vaccine. And in California, we try to get people vaccinated between October and November because typically we don't see the virus infection in California until probably later in the season. We see it more into January, February. East Coast does tend to get it sooner, so if people are traveling, we want to make sure they get vaccinated before they travel. So the vaccine doesn't protect against all strains. It's only 3 strains in most of the vaccines, but there is a quadrivalent, a 4-strain vaccine. But there's still other strains that are not contained in the vaccine that can still be out there. But this still gives you partial immunity, so it's better than getting nothing. Again, flu vaccines are updated every year. Most of the times we have 2 of the influenza A and 1 of the B. The quadrivalent has 2 A's and 2 B's. People with egg allergies, usually this is not a problem because these are no longer incubated in egg. If somebody has a very significant anaphylactic reaction to egg, there is one vaccine that is a recombinant vaccine, and that one has almost no egg particles in it at all. Anybody over 65 should get the high-dose vaccine, which we recommend. There's actually 2 forms of it. One is the high dose that just has higher antibody materials in it, and the other one is formulated. It's a tri- and a quadrivalent vaccine in an oil. And what happens is when you get the injection, then it absorbs much more slowly, and the body has more time to make antibodies. Because as we get old, our body doesn't make as much antibody response. So at Washington Hospital, we're currently screening all eligible patients. This is also requested by Joint Commission and CMS. So we do try to screen patients as they're coming in and being admitted to make sure that we make vaccines available, both the influenza vaccine as well as the vaccine for pneumonia. In the state of California and Alameda County, it's 100% mandated that our employees, volunteers, physicians, everyone who's in the hospital gets vaccinated. Workers have the option of declining, which we respect, and if they do, then they are told they must wear a mask anytime they are in patient areas. We also recommend that everybody do hand washing, my favorite thing. So anytime you're coming in contact with a patient, families, anybody, we need to wash our hands before and after each of those contacts. Again, the Joint Commission and CMS highly recommends that we do immunization for influenza as well as for pneumonia. And again, this is also through California Alameda County Health Public Department recommends, again, the vaccines. So this is where we have been in past years. We are trying to get upwards higher. So in the 2013 to 14, we had 88%. When it became mandatory for Alameda County, we got to 96% and 94%. This year, I'm told we're upwards of about 96% already. Again, this just lists the vaccination rate. We are at 100% when we combine the declinations plus the vaccinations. So what can you do to prevent? 1, get the vaccine. 2, wash your hands. 3, anytime you're coughing or sneezing, you want to cough and sneeze into a tissue or into your elbow. Try not to cough into your hands because you're going to spread it. So elbow or tissue. Wash your hands. The vaccines are available at the urgent care from 8 to 8. Appointments are not needed. They do take cash discounts, but they will also bill insurances. The other thing is if you think you have influenza, we strongly encourage people to get contact with their healthcare provider. There is treatment for influenza, but most effective within the first 24 hours. So even if you think you have the flu, it's best to contact your physician or your healthcare provider. Let them know your illnesses, let them know your symptoms, and between the two of you decide what's the most appropriate course. Questions?
Questions? No, thank you, Dr. Martin. Thank you. Okay, Chris.
Okay, good evening. Tonight we'll be looking at Washington Hospital's operating and financial results for September 2016. And we'll start with our inpatient statistics. Average daily census for the month came in at 142.7. The budget had expected 162.8. We had 908 admissions, 89 below the budget, and our patient days were 602 below budget at 4,282. Outpatient observation equivalent days were actually 121 above budget at 317 for the month. Average length of stay came in 0.2 below budget at 4.7. Looking at utilization, and you'll see what really drove those inpatient statistics. Case mix index for the month actually was above budget at 1.589. We had deliveries that were 3 below budget at 150, but our surgical cases were 59 below the budget at 362. That includes our joint replacement cases that were 21 below budget at 122. Our neurosurgical cases came in 3 below budget at 28. And our cardiac surgical cases came in 1 above the budget at 12. So the balance of that really was rounded out in general surgery being below budget. Cath lab procedures for the month, 92 below the budget at 318 for September. Outpatient visits, a little bit less than 10% below budget at 6,799, and the emergency room came in with 4,162 visits, 143 below budget. So really all of our activity was down in the month of September. We continued what we've seen the last couple months with lower volumes in the fall. Looking at our cath lab activity, we did have a bright spot in the cath lab. Our cardiac procedures actually were about 33% above the budget, so that offset a lot of the lower activity in there. Traditionally, those procedures, help buffer the revenue in the cath lab. So peripheral vascular made up about 36%. They were off their budgets, while while cardiac was up. Our non-vascular IR came in at 16% of the activity in the cath lab. Looking at productivity, productive FTEs for the month came in 62.6 below the budget at 1,194. We had 176.5 non-productive FTEs in September, giving us total FTEs that were 73.8 below the budget at 1,370.5. So management was really trying to get folks out of here and really trying to control those FTEs. Our FTEs per AOB, however, came in just a little bit above the budget at 6.78. We'd expected 6.61. We're getting down in volumes. It gets pretty tough to flex down to those. Looking at the financials for the month, our total patient revenue came in 7.3% below the budget at $161,692,000. Our contractuals, we continued to see some challenges with our payer mix. In fact, in the month, our government-sponsored patients were about 2% above what we had seen over the last year, and PPO were about 2.5% below as a mix, as their percentage of the mix in the revenue. So we ended up with contractuals at 77.54%. The impact on the net revenue, the additional load on top of the lower revenue of that was about $1.6 million. So we ended the month with net operating revenue about $4.6 million below the budget at $36,886,000. Operating expenses for the month came in about $1.5 million below the budget. That variance really driven by our salaries and wages with our lower FTEs. Supplies were lower, correlating with the lower activity in the house. And our provision for bad debt also was about $400,000 below budget. So we ended the month with an operating loss of a bit over $1.4 million for the month. Non-operating income for the month came in pretty close to budget, about $52,000 off at $1,627,000. So we ended with a total bottom line of $168,000. Of course, that's looking at it from the GASB perspective, the Governmental Accounting Standards Board perspective. We'll take a quick look at how the financial markets might look at it. Our operating bottom line stays the same. We pull out our tax revenue that supports the debt service on our GO bonds, and an unrealized loss on investments that was pretty small, about $33,000, and end up with a bottom line from a FASB, or the way the financial markets would look at us, of a loss of about $1.1 million. So are there any questions on September? Okay.
No, go ahead.
Okay, this will be the preliminary operations report for October. Our gross revenue for October was below budget by $14 million. That's an 8.1% negative variance. And it was lower than October a year ago by about 4.4%. Our inpatient gross revenue was $17.2 million below the budget, and the outpatient gross revenue was $3.2 million above budget, so it partially offset that. The major drivers of the unfavorable revenue variance appear to be, at this point, inpatient surgical cases that were below budget by 22%. That's huge. Our inpatient cath lab procedures were below budget by 21.3%. And these variances obviously resulted in lower admissions, fewer inpatient days, and a lot less inpatient ancillary service utilization. The major drivers of the favorable outpatient revenue variance include the outpatient cath lab procedures that were above budget by 27.5%, and outpatient surgical cases that were above budget by 13.7%. In terms of our census, the average length of stay of 4.49 was lower than the budget. We budgeted 4.76. Our outpatient observation days were also below budget, which is not an altogether bad thing. And the average daily census of 141 was 8.5% below budget, so we're having significantly fewer admissions. Our admissions are below budget by 8.4%, as I mentioned, and lower than last year by 3.1%. The lower inpatient surgical and cath lab volumes were the major reasons for these negative variances. In terms of patient days, we are 4,378 days for October. They're below budget by 408. They resulted in room and board revenue that was 12.3% below the budget. And our patient days in October of 2016 were 128 lower than October a year ago. In terms of surgical trends, in October, we were below budget by 59 cases, and that resulted in unfavorable variance for surgical services revenue of $3.1 million, or a 9.2% negative variance. Our inpatient surgeries were 72 below budget at 256, and our outpatient surgeries were 13 above budget at 108. Major surgical variance drivers included general surgical cases below budget by 55, joint replacement surgeries that were below budget by 3, cardiac surgeries that were below budget by 2, and neurosurgical cases that were above budget by 1. The cath lab procedures for October were 372, 5 cases above budget. Inpatient cath lab procedures were below budget by 42. The outpatient cath lab procedures are what carried the numbers. They were above budget by 47 cases. That's a 27.5% positive variance. In terms of peripheral vascular cases, they came in under budget by 25. Non-vascular interventional radiology procedures were below budget by 9. Neurointerventional procedures were below budget by 7. And these unfavorable variances were offset by cardiac procedures that were above budget by 46. Of note, the PTCAs, of which there were 45, were above budget by 23, and that should help with the revenue picture considerably. Deliveries for October came in below budget by 8. So we had 147 babies delivered at the hospital. Non-emergency outpatient visits amounted to 6,767. We were under budget by 935 visits, or a 12.1% negative variances. Lab visits were below budget by 553. Cardiac rehab visits were below budget by 193. I wanted to mention that one of our major insurance carriers suddenly, without prior notification, has decided that they are going to refuse to pay for cardiac rehab visits on the basis that that care is experimental. X-ray visits were below budget by 112. Emergency room visits were 150, 3.6% above budget, and 3.6% higher than a year ago. Our productivity indicators for FTEs came in below budget. We had staff trying to keep the employment level down, the working level down. They were under budget by 36.7. And non-productive FTEs were below budget by 20.2. Total FTEs of 1,356.8 came in below budget by 56.9 for 4% dip. So we have some more to do here, but it's a good sign that the management team is beginning to ratchet that down. Our productive FTEs per adjusted occupied bed of 5.89 came in 0.2% below budget. So the total FTEs per adjusted occupied bed of 6.68 was 1.2% below the budget. Other operational statistics include our surgery center. They had 467 cases in October. That was 25 cases fewer than we had budgeted. The clinic visits for the month came in at 4,109, and they were above budget by 34. Warm Springs had the biggest positive variance. They were up by 118 visits. Payer mix. The payer mix information on preliminary analysis looks very favorable and better than we've seen in the past few months. The government-sponsored patient revenue made up 68.9% of total gross revenue. We had budgeted 70.9%. This is down from 72.1% in the first quarter of the fiscal year. PPO revenue was 26.2% of gross revenue, and that is a very good sign. It is above the budget, which had been pegged at 23.7%. It was up from the last quarter. Private pay revenue was 1.6% of gross revenue compared to a budget of 2%. You begin to see how this month is beginning to shape up. Hopeful signs. And our key financial statistics, days cash on hand at October 31st was 215, unchanged from the prior month. The days in accounts receivable were 60, down from 63 days in September, which is also a good sign. There were $603,138 in charity care applications pending or approved in October. And just going forward, I think with the uncertainty about the Affordable Care Act, that we'll see the charity care begin to grow again as it existed historically, and possibly Medi-Cal shrinking down. The subsidies for these programs are over with, and I don't know what Congress will do. It all remains to be seen.
All right, well, thank you. Thank you, Nancy. We are now going to move into the consideration of the pipe replacement.
I have asked Ed if he would please review this with the board.
Thank you, Nancy. The pipe replacement would fall in the category of repair and maintenance projects. So the buildings now are, some of them are exceeding 50 years old, and most of them are exceeding 40 years old. And we have had to do replacement of pipes for a while. I'd say over the last 15 years, this has been an ongoing issue. Fortunately, a lot of the replacements have been above ground and in the basement of the facility that we've been able to replace. The kitchen has been a particular conundrum because all those pipes are under the basement. And we have done a variety of things to make repairs over the years. Over 10 years ago, or excuse me, approximately 10 years ago, I think it was actually 9, we went through a process. We had a lot of breaks and leaks, and we went through a process of coating the pipes down there to seal off problems. And we've got almost 10 years out of that process. But they're continuing to degrade, and we really have to go and replace all the cast iron pipes in the kitchen. It's a little bit of a the current arrangement is a little bit complicated because the pipes run all the way under the kitchen. They drain the dish machine, the cooking area in the kitchen, the line in the cafeteria, and the pot room. And then they run out, the pipes run out outside of the building, right by the physician entry, go through a grease trap, and then drop down about 30 feet and come back into the facility and go into a holding tank in the facility that then pushes it out to the sewer lines out on the street. So our plan is to make that a little bit simpler, replace the entire line under the kitchen, put it out to a new grease trap that's larger, and then run from there to the pipeline out on Maury, the sewer line out on Maury. So we'll have to do some digging up of parking lots and things like that to run it out there. So we're asking, it's an expensive project. Construction loan is slated to come in at $1.8 million, and then we have associated other costs that we have for any construction projects, so that the total budget is $1.962 million, and we're asking for that approval tonight. Any questions I can answer?
No, I think it's obviously has to be done. Unfortunate, but it has to be done. Okay, we have before us a resolution number 1175. So I am going to ask for a motion to approve resolution number 1175.
Mr. President, I move that the board approve resolution 1175, which is the kitchen pipe replacement project.
Thank you. Do I have a second?
Second.
Dee, please take the roll.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye.
Thank you. Is there any other business this evening? At least at this stage, we're going to adjourn to a closed session and then reconvene when that's finished. Thank you. Okay, we're going to reconvene the open session and announce that there were no reportable actions taken during the closed session. With that, the meeting is adjourned.